Hello everyone, Medic Level Up here. I'm back again with another video. Today's video is going to be about a right bundle branch block, and successively we're going to be studying about a left bundle branch block and fascicular blocks as well. The first question that comes to mind is why study about a right bundle branch block? Well, an RBB is going to be apparent on an ECG in multiple conditions such as an atrial septal defect, right to left shunts, pulmonary disease. In an acute pulmonary embolism, you can have a right bundle branch block pattern, and then it can be transiently present in an ECG after cardiac surgery, or the most common cause that is that it could be even a benign pathology on a ECG. Similarly, a left bundle branch block is much more important because it's considered to be a STEMI equivalent, but there's actually data that suggests that only 10%, less than 10% of patients actually have an acute myocardial infarction, but you just don't want to miss those 10% of cases. Other causes could be cardiomyopathies, valvular heart disease, and hypertensive heart disease. The first condition that needs to be satisfied for it to be considered a bundle branch block pattern is interventricular conduction delay, which is IVCD. A normal QRS complex is going to be less than 0.12 seconds. For an interventricular conduction delay to be present, an abnormal QRS duration needs to be present, which is more than 0.12 seconds. So the moment you see an IVCD, we will assume that there is some sort of a bundle branch block pattern, but that's not the only cause. You could have a wide QRS complex because of other reasons as well, such as drug-induced or Wolff-Parkinson-White syndrome. For this video, it's going to be mostly centered around bundle branch block patterns. The two leads to look at are lead V1 and lead V6. Now, essentially, I know that some of you have memorized the easy mnemonic, which is Marrow or William, but this video is going to explain why those patterns happen. So let's draw a nice little heart over here. We're going to go over the normal spread of electrical current through the heart. So normally what tends to happen is that the septum is depolarized because of the left bundle. So the septum gets depolarized in a fashion from left to right in this fashion. The second part is that the respective bundles take the current along to the respective ventricles, the right and the left ventricle. Let's consider a right bundle branch block. So consider the fact that in this heart, the right bundle has been surgically excised from the heart, and you only have the left bundle branch. We'll make a lead V1 over here and a lead V6 right here. And we're going to make the ECG leads over here as well. So essentially the first step is the depolarization of the septum, which is going to be from left to right. We'll draw a P wave over here. So this is how the current spreads first. So you've got a left bundle working perfectly fine. This current is detected as positive in V1 and goes up in V1. And at the same time, this current is negative in V6. So it goes down in V6. The second part is the current traveling along the left bundle into the left ventricle, negative for the V1 and positive for V6. So we can see that it goes down in V1 and up in V6. Now, what tends to happen is that when the heart senses that there is no electrical depolarization going on in the right side of the heart, it sends off a current from the left bundle into the right ventricle, which is shown here in gray. Now, what tends to happen is that this is positive in V1 and negative in V6. Hence, the waveforms are positive in V1 and negative in V6. After all the current dies out, it comes back to the baseline. So you get a small r, a negative S, and then a positive R complex again in V1, which is known as a small s, R, small r, big S, and a capital R prime. So this is an RSR prime pattern that you see in V1. Now, essentially, there can be different variations of this pattern as well, so you need to memorize those. That's why I never decide to go on a Marrow or a William pattern, so you can have it like this. You can pretty much have it without the initial septal R wave. You can pretty much have the notch at the top as well, or anywhere in the waveform. So let's ask a question. Why is there no septal R wave in this variation? in a right bundle branch block? Well, there could be many reasons, but here, for instance, I saw an ECG which didn't have a septal R wave, and I was told by a cardiologist that it's possible that that patient may have had a septal infarct, so you don't have the current spreading through that area. So it's very important to remember that there are variations of this, and it's not necessary that you sometimes might even see the notch. Now, what's complete and incomplete right bundle branch block? It's very simple. A complete RBBB is going to be a QRS with more than 0.12 seconds, and an incomplete will be QRS less than 0.12 seconds, and it just depends that there is going to be a right bundle branch block morphology in both of those conditions. The last thing I need to talk about is access when there is a right bundle branch block. So the access basically depends on two things. Number one is that the lost part of the heart is the right side being depolarized, so the access is going to be towards the right, and majority of the current is spent on trying to depolarize the right ventricle. So it is again towards the right. So I'm writing it down over here. So the major forces are towards the right, and the last part of the heart is the right-sided to be depolarized. Hence, the axis is going to be rightwards with a right bundle branch block pattern. Next thing is we're going to go over a couple of examples. So here we've got an ECG. If you look, the duration of the QRS complex is definitely more than 0.12 seconds. So immediately we're going to go over to lead V1 and lead V6. You can see that there is an initial R wave right here. There is an attempt to form an S wave, and then there is the R prime wave. So essentially this doesn't become the RSR pattern, or the mnemonic doesn't fit where you can call it just a Merrill pattern. So you guys need to keep an eye out for different variations of the right bundle branch block. An additional thing I want to point out over here is when you look at this entire complex with the T wave is inverted. This is basically known as secondary repolarization abnormalities that happen with the right bundle branch block. Next thing is we're going to look at a different example, and over here you can see again that the QRS duration is more than 0.12 seconds. So immediately go over to V1 and go over to V6. There is no initial septal R wave, there is an S wave, and there is an R prime wave. So this is basically a S or prime pattern. This is also a right bundle branch block. Again, you can see the secondary repolarization abnormalities. The next ECG is going to be a supraventricular tachycardia, which was being aberrantly conducted downwards. And if you zoom in over here, you can see the very typical pattern of an R, S, and R prime wave with secondary repolarization abnormalities. This is very typical of a right bundle branch block. Thank you so much for watching. Don't forget to like, share, and subscribe to the channel. As always, feedback and questions are appreciated, and have a good day.